Okay. Yes. Anyone? No. Dr. Nuria, can you just give us an overview? Can you guys see my screen? Okay, I think I haven't shared my screen.
No, cannot see your screen.
Okay. Can you guys see it now?
Yes.
Okay. So anyone who can just give us an overview of monobactums? Hello.
Okay, I'll try.
Okay. Yes.
Monobactums are they have a beta lactam ring. They
Okay.
are penicillinase resistant.
Okay.
They include the drug aztreonam.
Okay.
Um,
Perfect.
they are active against gram-negative bacteria,
Okay.
and they are treated. They can be used for treatment in patients who have penicillin allergy.
Perfect. And what's like if they are acting as a okay, if they have beta lactam ring, it's mean they're going to inhibit the cell wall synthesis,
Wall
right?
synthesis, yes.
Okay. And they are active against gram negative rod shape bacteria, right?
Gram-negative ones,
Okay.
yes.
So can you just give us an overview of this scenario?
Okay, this is the macrolides, and they have the name throw in them.
Okay.
So, azithromycin, erythromycin, they inhibit the 50S ribosomal subunit,
Perfect.
and they are hepatotoxic. They
Okay.
cause torsade de pointes. They could also cause GI upset, and they inhibit the CYP enzyme.
Perfect. Okay. So can you just give me an overview of this?
This represents the fluoroquinolones.
Okay.
They are they inhibit DNA gyrase and topoisomerase.
Okay.
Um, they also are teratogenic, and they could
Okay.
cause tendinitis.
Tendinitis,
Uh,
yes.
they have the name. Oh, I can't remember. Oh
Okay,
yes,
you
the
cannot
fluoxetine
take it with
name. You cannot
antacid.
take it with antacids, and they have the
Okay,
name flox in it.
flox, yes. And one of the drugs in this class which inhibits your CYP enzyme.
Ciprofloxacin.
Yes, ciprofloxacin. You can see this guy carrying some chips.
Yes.
Okay, 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 good. So, can you just give us an overview of this antibiotic?
Okay, this one is the chloramphenicol and inhibits the 50S ribosomal subunit.
Okay,
It causes anemia and gray baby syndrome,
okay,
and it also causes what's that? Anemia, aplastic anemia.
aplastic anemia. Okay, perfect. So, okay. Okay. So we are done with the and almost done with the antibiotics. So today we are going to discuss some bacteria. First of all, we are going to discuss gram intermediate bacteria, right? What's gram intermediate? It means or gram variable. Okay, so you are going to see both purple and red stain under microscope, right? So it indicates that they are neither gram positive, neither gram negative. They are in between, intermediate, right? Hello.
Yes.
Okay, so in this scenario, you guys can see that we have a garden, right? And there are some, you know that some kind of that flowers, that fly trap. If you guys remember fly trap kind of flower, they just trap on the flies and they just eat them, right? So here is a garden, and we have this fly trap of flowers within this garden. Okay, so for basically these, you know, this gardener is giving it like fertilizers, and he's using some dead fish residues as fertilizers, right? Because all of the organic things can be good fertilizers, right? Hello.
Yes.
Yes.
Okay. So you can see she's also flowering the garden as well, and like she has just clamp of her nose because of the bad breath or bad smell coming out of these rotten fish, right? And other you can see these kind of, okay, here, like another gardener is just cleaning these uh, like for the dust, you can say, with the tissue papers, right? Tissues. She's also carrying some bleach or soap with herself in order to clean this track. You can see this track. So this track have certain kind of, you can see that cells kind of that cobblestones, you can see. And like around these cobblestones you can see these pollen grains that are surrounding these cobblestones, right? And at the back you can see this metro train going over on its track, right? Okay, so, and you can also see that bad smell coming off these rotten fish that she's using as fertilizer, and as a result of that, it's uh, like producing some bad fishy smell. So basically, here we are talking about the garden should make you remind gardenella, and these fly trap kind of flower should remind you vaginalis, vagina, right? So we are talking about gardenella vaginalis, gardenella vaginalis, garden for gardenella, and these flowers shape should remind you vaginalis. So gardenella vaginalis, right? So now let's discuss what are some risk factors of one having Gardnerella vaginalis growth inside vagina. Simple, okay? So, okay, first of all, you are going to see like a black kind of discharge out of vagina, okay, blackish discharge, and it would be having a fishy odor because we are using fish here as a fertilizer, and they are producing some bad smell. So what's the characteristic finding? You are going to see fishy odor with some grayish or blackish kind of discharge, right? Okay. So how, what are the some risk factor of developing Gardnerella vaginalis? You can simply think of, as we discussed, the bacteria that was C. difficile, right? If I am having more space, if I am using antibiotics, so it means in GIT you have more space for these C. difficiles to grow. And if I'm having more space for the C. difficile to grow, so it can cause pseudomembranous colitis, right? So same is the case with Gardnerella vaginalis. For example, if one is undergoing vaginal douching, right? You can see here she's cleaning these flat trap kind of plants. Okay, so it should make you remind that vaginal douching is one of risk factor for growth of Gardnerella vaginalis, that is gram intermediate, right? Secondly, use of antibiotics can also cause Gardnerella vaginalis. Like you would be having more space for this Gardnerella vaginalis to go inside vagina, give you this fishy odor and blackish or grayish kind of discharge. Secondly, like here we were discussing these cobblestone being arranged on this track. So these cobblestone stones and pollen grains are attached on the peripheries of these stones. It should make you remind of certain cells that are basically diagnostic. Under microscopy, you are going to see clue cells. You can see these are basically clue cells, and these clue cells are going to be surrounded by Gardnerella vaginalis. That these are basically vaginal epithelial cells that are being surrounded by your Gardnerella vaginalis bacteria. Simple. Okay. Secondly, how to diagnose? Normally, the pH of vagina is acidic. Okay, if you have basic pH, it also indicates the overgrowth of Gardnerella vaginalis. How to remind that? This lady is basically carrying some bleach or soap, and it's like the soap and bleach is basic in nature, right? So what happens? The pH is going to rise. So rise in pH also indicates towards overgrowth of Gardnerella vaginalis. Okay, so another thing, you can see this bad smell coming out of these fish, and she have just uh, she's just closing her nose in order to avoid this bad breath. So it's basically producing a whip-like structure. You can see it's a whip. So thirdly, you can also undergo a test that is known as whiff test diagnosis of whiff test. Let me revise it again. You are basically going to see three things. One, you are going to see clue cells, and clue cells are vaginal epithelial cells, and basically this Gardnerella vaginalis is going to surround them, right? These cells. Secondly, the pH of vagina is going to become basic. How to remind that? You have this basic pH or soap, uh, like she's cleaning this floor with this soap, this basic pH soap, simply. So basic pH also indicates towards overgrowth of Gardnerella vaginalis. Thirdly, you can remind of this whip. So whiff test is also used to diagnose the overgrowth of Gardnerella vaginalis, right? What are some of the treatment options? Very simple. You have a metro train. So metro for metronidazole, right? Metronidazole. And she is using the Kleenex brand of tissue paper. So Kleenex should make you remind your clindamycin. Okay, so let me revise it again. You have a garden and you have that by trap kind of flowers inside that. So garden and that fly trap kind of flower should make you remind your Gardnerella vaginalis. What are the risk factors? Vaginal douching. Secondly, use of antibiotics. Okay, what am I going to see on how to diagnose? You have three criteria for diagnosis. First of all, you are going to see clue cells, these cobblestone surrounded by Gardnerella. Okay, by these pollen grains should make you remind that these vaginal epithelial cells are going to be surrounded by your Gardnerella vaginalis bacteria simply. Secondly, the pH is going to increase. You're going to have basic pH. Thirdly, a whiff test can be used to diagnose Gardnerella vaginalis. Okay, so how to treat them? Just give them metronidazole with Kleenex, that is clindamycin. Anyone who can just give us an overview of Gardnerella vaginalis, please?
Yeah. Should I go on?
Yes, Dr. Ramesh, please.
Yeah. Okay. Here as you are seeing that by the shape of the flowers, we are talking about Gardnerella vaginalis, and it's a variable gram. It's purple and red, which suggests it's gram variable. So I
Okay.
and the risk factors are vaginal douching and use of
Yes.
antibiotics,
Okay.
and by the bleach bottle we can see that uh, mm, basic pH. Was it it was
Yes.
basic pH, and the due to the pollen grains clinging to the cobblestone, so it suggests that diagnosis is done by the clue cells.
Yes.
Okay, and they are due to the it is diagnosed by the whip test, and treatment is done by metronidazole and clindamycin.
Okay. What? Yes. What about this fishy odor and gray discharge? You must remember that
Yes,
too.
yes.
Yes.
The rotten fish will suggest that there will be a fishy odor and the release discharge.
Yes. Perfect. So now let's do another one. Okay. Hmm. Okay. So in this scenario, you can see an. Okay, just give me a second. Okay, in this scenario, you can see a bird's house, a big bird house. You know, birds are also known as avium, right? So in this scenario, basically, we are seeing an aviary, right? Avium for aviary, right? Or avium for birds. So you can see these birds are basically sitting on this rod shaped kind of stands, bird stands, right? And here you have a grandma. She's just like very old, so she's carrying this stick with her, walking stick with her, right? And she's just putting some lemon on the macaronis in order to eat something, right? Okay. Secondly, you can see a pink flamingo, and this flamingo is trying to eat this lemon. Okay, like this flamingo is trying to eat this lemon. Okay, so the aviary should make you remind that, or avium should make you remind that we are studying mycobacterium avium, right? This aviary or the bird house scene should make you remind that we are talking about Mycobacterium avium. Okay, it's rod shape. Why? Because all of those bird stands are rod shape. Okay. Okay. Secondly, you can see here the grandma. So in the pictures, grandma basically indicates granuloma. So it's a granulomatous disease, right? Granulomatous disease is basically driven by Th1 cells. If you guys remember, it's going to recruit your macrophages, and macrophages are going to surround the site of infection, and ultimately is going to result into granuloma formation. Okay, so as the grandma is old and she's carrying this stick, so carrying stick should make you remind that she's an immunocompromised. Her immunity is very low, so it means this bacteria basically, it's I'm still talking about gram intermediate bacteria, right? So it means that there is high risk for the immunocompromised population to be affected by this bacteria, right? Okay. Another thing which is very important, you guys must know, this like lady, this old lady is basically like squeezing some lemon juice over this macrolide. So this lemon is acidic, right? And flamingo is pink. So you must remind that it's an acid fast bacteria. Acid fast. Okay. Okay, what is acid fast bacteria? It's very simple. For example, if this is my bacteria and I just stain it with Zeal Nelson stain. Okay. So then I wash it with some acids. Okay, normally if I wash a bacteria after being stained, the stain should move away, the stain should go. But even after washing it with acid, the stain, the Zeal Nelson pink stain, it's basically pink, is retained. You cannot wash off this stain. Why? Because it have a high mycolic acid content. Due to mycolic acid present in their membrane, they basically love to hold this stain. So that's why we can also use, it's an acid fast, or it loves to bind with the stain. Okay, so it's an acid fast bacteria. By the way, every mycobacterium is rod shaped and acid fast, which we will be discussing further, right? What are some of the treatment options for Mycobacterium avium? Just give them macronides, macrolides. Already we have discussed 50S inhibitors. Let me give you an overview. Every for Mycobacterium avium, rod shape, it is going to give you granulomatous disease. Basically, immunocompromised population is going to be affected more. It's an acid fast. Why? Due to high concentration of mycolic acid, it loves to hold the stain even after washing with acids. So, anyone who can just give us an overview, Dr. Amis, please. Hello.
Yeah, yeah. Hi, sorry. So here is the scene of aviary. So which suggests that we are talking about Mycobacterium avium.
Okay.
It is rod shaped, and
Yeah.
by the cane, it suggests that immunocompromised patients are at risk of this disease.
Yes.
But it presents as a granulomatous disease, and
Okay.
by the lemon, it suggests that the bacteria is an acid fast bacteria.
Yes, it's an acid. What do we mean by acid fast bacteria, please?
Because the dye get like stings to clings to the mycolic acid and doesn't get decolorized by the acid.
Yes. Okay.
Okay, and it's
So
treated by macrolides.
perfect. So this was all about Mycobacterium avium, right? Okay.
Doctor, can you
So
explain what does it mean by acid fast?
okay, acid fast mean that even after washing this bacteria with acid, it holds the Ziehl-Neelsen pink stain. Why? Because it have high mycolic acid concentration. Mycolic acid do not let this stain to be washed off even if I am using acid. Normally, if I just like wash a bacteria after staining with Zil Nelson said, wash it with acid, the stain would go. But here the stain won't go. Why? Because it have high mycolic acid concentration. Simple.
Okay.
Okay. So this was all about Mycobacterium avium. Now let's discuss this. Okay. So in this scenario, you guys can see we have a scenario. Okay, just give me a second. What's happening? Okay, so in this scene, basically we have a zoo. You can see one of the person just entered the leopard cage, and leopard attacked him, and the leopard just knocked him down, and now he is dead. You can see some scratches over his body. Okay, and he was just bringing some. He just brings some lemon pink kind of juice with himself, and lemon along with that lemon. You guys must remember that. Okay, and he is dead now. So he this leopard also took both his shoes, okay, and he just scratches him off and until he died. Here at the back you can see an armadillo have also entered this scene, right? He is just roaming around here and there simply. Okay, this leopard is standing upon, you guys can see here the rod shaped log, right? Or here you can see another female. This leopard just she had a mild scratch from this leopard too, and she escaped, and she have a tube that is surrounding her. She just wears some tube. I don't know why. Okay, and now she's calling for first aid help because she also gets scratch from this leopard, and this is basically a danger zone. You must not enter here, but he was like, uh, he had bad luck and he entered and he died. Okay, here you can see the police coming. He just load off his rifle and he's coming to the scene, right? He also wear that fancy kind of clock. Guys must remember it too. Okay, so leopard should make you remind that here we are discussing Mycobacterium leprae, right? Mycobacterium leprae, right? Leopard for leprae. Okay, so this leopard is basically standing upon this log. So this log should make you remind that it is rod shaped, right? Mycobacterium leprae is rod shaped. You have two variants of diseases which are caused by these bacteria. Okay, here we are also going to have some immunological tie-in, and I'll be asking you guys because we are already done with immunology. So the first form, here you can see this lady, she's just like wrapping around this tube around her back. So this tube should make you remind that one form of Mycobacterium leprae infection could be tuberculoid form. Tube for tuberculoid form of Mycobacterium leprae, right? Hello,
Yes.
are you guys following me?
Yes.
Okay, it's a tuberculoid form. Okay, let me give you a clue. It's an intracellular. It's an intracellular infection of Mycobacterium leprae. So whenever we have an intracellular infection, can you guys tell me we are going to see Th1 response or Th2 response?
Each one.
TH1
Th1.
response.
And if we have an extracellular infection of leprae, let's suppose, so then we are going to see Th1 or Th2. We have
Yes,
already
too.
discussed Th2. Perfect. So now you have made things easy for me as well. You can see the tubercular form. It's an intracellular, so you can see the first aid help. Okay, first aid. So the first should the helper one cell, that is Th1 driven, right? It's a Th1 driven response, right? So it's primarily Th1 mediated. Why? Because it's an intracellular infection of Mycobacterium leprae. Simple. Okay, so what's the carrier first? Let's talk about the carrier of leprae. Very high yield. It's basically carried by armadillo. Here, okay. So it's like it's have like a rare kind of carrier. So it's very high yield. You must know that armadillo in US is the most common reservoir for Mycobacterium leprae, right? So the tuberculoid form, and it's a milder form, because in this case you can see she only had a mild kind of scratch from this leopard. So it's a milder form of Mycobacterium leprae. You are only going to see some skin rash. Okay. Okay, so how to test it? It's simple like PPD. What did we do in PPD? We just inject some of the purified form of tuberculin, right? And that was driven like type 4 hypersensitivity. It's going to produce an indentation over the injection side, right? Where we are injecting the tuberculin. So here what we do, just give them lepromin, which is an antigen of this bacteria. And what happens after some time, 48 hours, you are going to see an indentation there. So it would indicate that yes, this person has been infected by Mycobacterium leprae, right? Hello.
Yes.
Yes.
Right.
Okay, so it's basically type 4 hypersensitivity, right? Already discussed. Okay, so one another form which is like dangerous form of Mycobacterium leprae infection can be it due to it's known as lepromatous leprae, right? So here you can see the angry leopard should make you remind lepromatous form, tuberculoid form and lepromatous form. So angry leopard for lepromatous form. So it's very like lethal. It can cause death. Here in this scene you can see this. Basically this leopard just knocked him down till death. So it's the severe form of mycobacterium. It's an extracellular. So please tell me, it would be Th1 or Th2 response?
Two.
Stage two.
Th2 response. How to remind that? You can see the pair of chews within his mouth. Basically, it's going to indicate 2 or Th2 response, right? Okay, another thing, it's an acid fast. I told you whenever you have mycobacterium, it would be rod shaped and it would be acid fast. Here, how to remind it that it is acid fast? This guy was carrying some pink juice with himself along with this acidic lemon, right?
Yes.
Hello. Okay.
Yes. Yes.
Okay. And what would be the presenting features here? You are having a mild rash, but in this case, you would be seeing a diffuse rash throughout the body, and you are also going to see some characteristic finding like this. Leopard face should make you remind that you are going to see leonine faces. What is leonine faces? Like loin-like faces. Why would be I seeing loin-like faces in lepromatous form? Because these diffuse rashes can spread over the skin of your face. They can just deform your face along with the nose, so you will be seeing some loin faces kind of appearance in this case, the lepromatous form, right? Okay, and it can cause death. Okay, what are some of the treatment option? Very simple, it's a danger zone. So danger zone should make you remind that dapsone is one of the treatment option for mycobacterium leprae. Secondly, you can see this police is carrying this rifle, so rifle for rifampin, right?
Okay.
Okay, okay. So this was all about Mycobacterium leprae. So anyone who can just give us an overview, and this kind of lepromatous form basically it's non-reactive to lepromine. Only the tuberculoid form, because as you guys know it's a type 4 hypersensitivity, and type 4 hypersensitivity you are going to see activation of Th1 cell, formation of macrophages and some memory cells. These macrophages are going to go to the side where you are injecting lepromine, for example, and it's going to form an indentation. But it's Th2 driven. So in Th2 driven, you do not have any macrophages, so you won't be seeing any reaction of insertion of lepromine or injection of lepromine into the side, because it's Th2 driven. You do not have any macrophages because type 2 hypersensitivity requires macrophages, right?
Yeah.
Right.
Okay. So anyone who can just give us an overview of this scene. It was quite an interesting scene, by the way. Okay.
Uh, okay. Okay. I am doing it. Mm,
Okay.
yeah. So here we see a picture of an sanctuary. So and there is an angry leopard, which suggests that we are talking about Microbacterium leprae, and it can Microbacterium leprae can be of two different forms. First of all, is the tuberculoid form, where there is like very mild skin plaques, and it
Yes.
is, yes, there are very limited scratch. So it suggests that in tuberculoid form there will be very limited amount of skin plaques, and
Yeah.
it is mediated by Th1 response. So primary helper T cells are getting involved here, and this kind of form is reactive to lepromine skin test.
Yes.
And now the second form is the more dangerous form, which is hmm, which is mediated by Th2 or Th2, and
Yes.
and there we can see there are like extensive skin rashes, and it is
Yeah.
very severe. It can cause it can be fatal, and there we can see the presence of leonine phases,
Yes.
and it is mediated by Th2 response. And
Yes.
since it is mediated to Th2, so there is no memory cell formation, and so it is non-reactive to lepromin skin test.
Okay. It's
And
an acid fast. What's the carrier?
it's an acid fast, and the carrier is armadillo, and it's a
Yes.
rod-shaped bacteria.
Okay.
And and we treat this disease with dapsone, rifampicin,
Yeah.
and what is that? A clock,
Dapsone clock for. Okay. It's
clofaximine.
clefazimine. Clefazimine. Clofazimine. Clofazimine. Okay. Clock for clofazimine. Okay. So this was all about. Okay. Lepre. Now let's discuss another. Okay, we are done with one, two, and three. Okay, let's do the fourth one. Okay, so it's very easy here in this scene. You can see we had some proclamation, you know, from a king. Okay, just give me a second. Okay. So here you can see a big scroll, and this guy is just having a proclamation. He's just reading that you should follow these rules, this and that. Okay, so for that reason, he has having a big kind of when he the scroll. So in the on the other side you can see that this scene is basically occurring at a lake side. You have a lake in behind. Okay, and thirdly, this child is coming and he dropped some pink juice along with the lemons upon that juice on this proclamation, kind of, this big page, simple. Okay, and his mother is basically catching him from his collar, and here you can see, due to you know pulling of the collar, he develops some red kind of rashes on his neck. Okay, so this crawl should make you remind that here we are talking about Mycobacterium scrofulaceum. Mycobacterium scroll for scrofulaceum, right? Okay, this pink drink along with lemon should make you remind that it's an acid fast bacteria, right? Okay, so this kind of bacteria is basically found in water reservoir or water sources. The Mycobacterium scrofulaceum is basically found in water sources or water reservoir, and basically children are more prone to have infection by M. scrofulaceum. Okay, once they okay in the clinical history, you would be having a child. He just visited to some water resources, or he was just like swimming in the open water reservoirs, and after that he developed enlarged lymph nodes or painful lymph nodes. This cervical lymph node basically. This red kind of rash after his mother is just pulling his shirt from his collar, so it's causing a red rash. It should make you remind that it causes cervical lymphadenitis, or cervical lymph nodes are going to be infected, and they are going to become reddish and painful. So this was all about M. scrofulaceum. So anyone who can just give us an overview?
Should I do it?
Yes, please.
Okay. Okay. So as we can see, there is a scroll which suggests that it's Microbacterium scrofulaceum. Um,
Yes.
it is a rod-shaped bacteria, and it is acid fast because of the
Yeah.
pink lemonade, and
Yeah.
it generally affects the children. And its natural source is like in water, freshwater lake, and it
Yes.
causes cervical lymphadenitis. Say cervical lymphadenitis.
Lymphadenitis. Yes. So now Dr. Zainab is going to give us complete overview of the bugs which we did today. Okay. Just give
Okay.
me a second. First of all, the first one. Yes.
Okay. The first one is the garden. The
Yes.
garden reminds us of a gardinella, and the flower shape reminds us of vaginalis.
Yes.
And the fishing odors, and there will be fishing odors with gravish discharge.
Yes.
And also, what are the risk factors? The risk factors are using antibiotics increase the risk factors for these infections. And
Yes.
also, vaginal douching also increases the risk factors. And what we can see what closets. These are actually epithelial cells of the vagina which are surrounded by the Gardnerella vaginalis
Yes.
infections. And also
Yes.
increased pH also. The SOP in bleach reminds us that increased pH. Also, we can see by diagnostic tests or increased pH, and also web tests we can do. And the treatments are metronidazole and clindamycins.
Yes. Perfect. So, can you just give us an overview of this? Yes, Dr. Zainab.
Okay. The lepers remind us Mycobacterium lepra.
Yes.
Yes, in this, the leopard stands on the log that remind us road shaped.
Yes. Okay.
Road shaped, and we have two types.
Yes. Type 1
Yes.
tubercular form.
Yes, type 1 is
Okay, first of
tuberculosum.
all, it's an acid fast, right?
Yes,
What's the carrier?
kidney is armadillo.
Armadillo. Okay.
Yes, and
Yeah.
we have two types. One is tuberculoid form, and the tube on the
Yes.
gall reminds us that is tuberculoid form,
Yes.
and it is intracellular. So in the
Yes.
gall is calling for first it help. It means that this is Th1 response, and it's less severe,
Yes.
and it's reactive to lepromine. And we will
Yes.
have
Skin test.
observations after 48 hours. It is a type 4 hypersensitivity reaction.
Yes. Perfect.
And the second type is lepromatous lepro, the angry lepers. It means that it's very severe form. And
Yes.
the pair of shoes remind us Th2 response.
Yes.
And we will have diffuse rash,
Yes. We're going to see. Yes.
and it is more deadly.
Yes. It's more deadly. And what about leonine faces? Leonine faces.
Yes,
Leonine like.
like line like face.
Yes. And what are some of the treatment options?
Dapsone
Yes. Dapsone.
and rifampin, the Ripo.
Yes. And clofazimine. For the red clock here. This red
Yeah.
clock should make you remind of clofazimine. Okay.
Okay.
Yes.
And birth house, we also call birth avium,
Yes.
every birth house. Okay, and the grandma reminds us there is granulomatous inflammation, granuloma
Yes.
formation, and it's a
Yes.
Th1 response.
Okay.
And the avium reminds us Mycobacterium avium,
Yes.
and the lemons and the lemon reminds us and flamingo, which is pink, acid fast, and
Yes. It's
the
acid
walking.
fast.
Yes, and the walking stick on the grandma reminds us this affects people who are immunocompromised.
Yes.
Yes, and it is rod shaped.
Okay. Perfect. So, can you just tell us? Okay, the last one here.
Yes, and the proclamations. And yes, this is Mycobacterium uh,
Scroll
scroll
for scrofulaceum.
scrophalaciums, and
Yes.
also the pink juice and the lemon remind us it's a sail fast. And the leak reminds us this is the water or the reservoir of these bacteria.
Yes.
And the child reminds us these are more common among children.
Yes.
And after usually children who are swimming, they get a large lymph nodes and causes lymphadenitis.
Yes. Okay. So it was all about the gram intermediate form of these bacteria, and we are left with one or two. Okay. That will be continued tomorrow. For now, let's discuss the red blood cells. Okay. Hello. Hello.
Yes.
Hello. Okay. Yesterday we did hemostasis, and today we will be doing red blood cells, and you guys are going to participate very well, right? Okay. So, can you guys tell me that what is anemia? Let's start with the simple concepts. What's anemia?
Decreased hematocrit.
Okay, decrease hematocrit. Okay, or decrease in red blood cells mass, right? Okay,
Yes.
so can you tell me, for example, if a person is having anemia, what would be the presenting signs and symptoms?
Shortness of breath,
Fatigue.
fatigue,
Okay,
Yeah.
perfect.
Pallor,
Pallor.
pallor,
Okay, perfect.
weakness.
Weakness, perfect. Okay, can you tell me that what's the uh, like? Can you just tell me that the normal level of hemoglobin in male and female?
12 to 7.
female 12, male 15.
Okay, 12.5 female, the end, the last end of. Okay, and 13.5, you're male. Okay, so can you just tell me the normal mean corpuscular volume of red blood cells?
88 to 100.
800.
Okay, 80 to 100, right? So, for example, if it's less than 80, it would indicate microcytic, right?
Yes.
And if it's greater than 100, it would be macrocytic, right? Bigger,
Yes.
macro. Micro
Yes.
for less. Okay, so now let's discuss microcytic first. I already give you an overview. Hemoglobin basically is made up of heme plus globin. Heme is made up of your iron plus, yes,
Prosoporphyrin.
okay,
Porphyrin.
porphyrin plus globins. If you have any defect with either one, you are going to see
Microcytic.
less hemoglobin, and less hemoglobin, you are going to see an extra division of your red blood cells, what would result in microcytic, right?
Yeah.
Okay, so the first one is your iron deficiency, Fe deficiency. So, for example, if a person is having iron deficiency, what will happen to the level of heme? It would decrease. What will happen to the hemoglobin? It would decrease. And you are going to see microcytic anemia. Simple. Can you just tell me some of the conditions in which a person is more prone to have less iron intake? What are some of the conditions which causes iron deficiency anemia or microcytic?
Malnutrition.
Antacids.
Okay, malabsorption. Then
Antacids
Increased
means
Rejection.
stomach
Gastrectomy.
rejection.
okay, you just one by
Just
one. Okay,
gastrectomy.
Gastrectomy.
okay, gastrectomy. Okay, like you cannot reabsorb. Okay, so it would result in microcytic anemia, right? So that day we discussed that how your iron is transported. Can you guys just tell me, for example, if iron enter your enterocyte, first of all,
By capsicum.
Ferroportin.
okay,
Ferroportin.
ferroportin. Ferroportin is going to bring it into your blood. In the blood, what's the name of your transporter?
Transferrin.
Okay,
Transferrin.
transferrin. It's going to transfer the iron into two main reservoirs, macrophages plus,
Bone marrow.
okay, bone marrow. And the main reservoir in which your iron is stored, what's the name for that?
Ferritin.
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 Perfect. Okay, so for okay, or iron deficiency anemia, you can also see pica along with that. You guys know what's pica?
Appetite for
Hello.
non. Yes. Appetite for
Yes.
non-nutritive things.
Yes, appetite for not non-nutritious things. Like simply, you can think of he would try to find iron in non-nutritious things. Simple. So he would be eating soil. He would be eating clay. Simple. Okay. So yesterday, that day we discussed whenever the levels of ferritin decreases, what happens to TIBC or total
Increased.
increases. Okay, so they both of them go in opposite direction to one another. I would be really fast with this portion because we have already did it, right? So
Mm.
stages of iron deficiency. First of all, your stores are going to be depleted, right?
Yeah.
Like first of
Yes.
all, you are going to see decreased ferritin, right? So if the
Yes.
ferritin decreases, what happens to TIBC? You have more transporter being dumping into your blood in order to
Increase.
catch. Okay, TIBC increase. TIBC would increase. Perfect. So what would happen to the saturation? By the way, saturation of your
Normal.
carriers decreases.
Yeah.
Okay. Okay. Secondly, then your serum iron is going to be affected. First of all, your iron store. Secondly, your serum iron. Okay.
Decrease.
Then yes,
Decrease.
that it would decrease. Okay, serum iron would decrease, and then your percentage saturation is also going to be decreased. And ultimately, first of all, you are going to see normostatic anemia, right? For example, if the stores are decreasing, you have less iron. As the iron level drops down more, then you are going to see microcytic anemia. So first of all, like you can simply think of, first of all, your bone marrow would compensate. It would produce normal red blood cells, but it would decrease the concentration of overall red blood cells. Like you are going to see anemia, but it would be normocytic, right? Right after that,
Yes.
it could not compensate. You have less level of hemoglobin further because you are progressively decreasing your iron. So then it would lead to microcytic anemia, right? So first of all, normocytic, then you are going to see microcytic. Okay, so second condition, this was all about iron. For example, if I have iron but it is being stuck inside your macrophages and inside your bones. Okay, what can just sequester this iron in these two resources? Which condition, please?
Hemochromatosis.
Okay, anemia of chronic disease. For example, if someone have chronic infections, he is going to produce acute phase reactants, right? Acute phase reactant, for example, hepcidin, and it won't allow this iron to come out into your blood and being used by your bone marrow in order to make your red blood cells, right?
Yes.
Okay, okay. Acute phase reactants. Why is it an is it isn't letting this iron to come out because your bacteria also loves to eat iron. Okay, so in order to stop those bacterial growth, it's basically having this kind of approach your body. So hepcidin is going to
Increase.
sequester. Okay, what happens to hepcidin?
Increasing.
Okay, hepcidin would increase. Okay, so what happens to your ferritin stores?
Increase.
Increase.
Ferritin
Increase.
stores would increase. What happens to TIBC?
Decrease.
Decrease.
Reduce.
Decreases. What happens to serum iron?
Decrease.
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 Yes, it would decrease. And what happens to percentage saturation of your iron?
Decrease.
Decrease.
Decrease again. Yes, perfect. Okay. So, what would happen? Okay, what would happen to the level of protoporphyrin? Free protoporphyrin
Increase.
Normal.
increases. It would
Normal.
increase because no, it would increase. Why? Because I am not forming. We do not have iron, but still the iron when bound to protoporphyrin. So if iron isn't there, protoporphyrin level is going to rise. Simple.
Free.
Okay. So another, okay, here we are done with the iron. Now let's discuss the condition which is associated with
Dr.
protoporphyrin.
Smith, may you one more time explain about why protoporphyrin is high in low film Fe
Okay.
condition?
Okay. So you know heme is made up of your iron plus protoporphyrins, right?
Yes.
If I do not have iron, it means I'll be having more free protoporphyrin. Like these protoporphyrin, they have no one to bind with. So they would be free.
Mm.
Normally, I won't be seeing free protoporphyrin in my in my body. Why? Because they love to join with iron. Because and now in this condition, we have sequestered all of the iron in those reservoirs. We do not have iron. It means I'm going to see increased protoporphyrin inside my blood, which is abnormal kind of, right?
Okay, thank
Okay.
you.
Okay. So
Can you just
hello.
explain why TIBC will be low?
Why?
TIBC will be low.
Yes, you can explain.
No, can you explain?
Can I explain? Okay.
Because
Sorry, I was just okay. So, whenever you have okay here, for example, these are your ferritin reservoirs, right? Okay, these are your transferrin, right? And transferrin basically indicates your TIBC.
Okay.
That is binding, binding to iron. They are going to bring iron inside your reservoirs, right? Hello.
yes,
Yes.
Transferrin is going to bring iron into reservoir. For example, if I have good reservoirs, right? So I don't need TIBC. I don't need these transferring molecules to bring more. Kindly, please, can you turn off your mic? Someone's mic. There is some kind of documentary going on in the background. Okay, thank you. So here you can see the transferrin. If I have good reservoir, it means I do not need these transfer molecules to bring out more iron, right? So their level is going to drop down.
Okay. Okay.
So if ferritin increases, TIBC decreases. If I have poor reservoirs, so my body will be sending more transporter in order to bring more iron.
Okay. Yes.
Okay, so they all goes in opposite with one another. So the third
Okay.
condition, for example, if we have certain deficiency with protoporphyrins, okay. For example, if protoporphyrin that we discussed, okay, if protoporphyrin is low, it means heme is low. If heme is low, it means you are going to see microcytic anemia, right? Okay, just give me 2 minutes, right? Let's have 2 minutes of break, please. Hello. Hello.
Yes.
Okay. So we were discussing a condition in which we have problems with protoporphyrins or porphyrin. What do you guys think? Hello.
Yes.
Okay. What do you just give me the name of that condition which is associated with problems of protoporphyrin? What's the name of that? Please give
Red
me.
Pharyngias.
poisoning.
Yes, sideroblastic anemia, right? You are going to see ring sideroblast. We discussed that day, right? You have the pathway. Which pathway? For example, amino linoleic acid is going to be converted into succinyl coenzyme, right? Okay, okay. Basically, succinyl coenzyme is going to be converted into. Okay, we have an enzyme here. What's the name of that?
Synthesis.
Allocentric.
Okay,
The
ALS synthase.
synthesis.
ALS. Okay, then what's the next step?
Um,
The aldehydrase.
Okay,
Porphyrin.
Ella, Ella dehydrase. It's going to convert it into yes,
Porphobilinogen.
yes, porphobilinogen, and ultimately you are going to see protoporphyrin. Simple, and you need ferrochelatase in order to attach iron with itself. For example, if you have certain condition, we are blocking this enzyme, ferrochelatase, and this one, Elas. That is lead poisoning, right?
Red poisoning. Yes.
Yes. So what happens? You are going to see a ring sideroblast. How this iron won't be participating in the, they won't be entering in the mitochondria in order to participate with, in order to participate in this process that is binding with protoporphyrin. So iron are going to accumulate around the mitochondria, and it's going to give you that ring sideroblast. Sidrin for iron. Simple. Okay. Okay. For example, if one have B6 deficiency, as we need B6 as a cofactor as well, it can also cause ring sideroblast. So you guys are going to tell me what happens to ferritin, the iron stores.
Increase.
Yes.
Increases. So what happens to TIBC?
Decrease or normal.
Yes, it can be normal or it can be decrease. Okay, what happens to serum iron?
Increase.
Increase. What happens to saturation? Increase as well.
Increase.
Okay, so now we are done with all of these three. Okay, now we are left with globins, right? You also need globin for production of hemoglobin. Simple. So if you have any pathologies that are associated with the globin chains, it means again you are going to see less hemoglobin is being formed. Less hemoglobin is going to give you microcytic anemia, right? So all of the pathologies which are associated with this globin chains is going to give you microcytic anemia. And what are those pathologies? That are
Sickle
thalassemia. For
cell.
example, if
Sickle cell
yes, sickle
anemia.
cell disease. Yes. So there can be two diseases. For example, if there is certain defect, if we have certain defect in globin chains, and if we are producing less globin chains, less globin or no globin. So we will be discussing this condition, less or no globin chains. It's going to give you less hemoglobin. Less hemoglobin, again you have microcytic anemia. So first of all, let's discuss the condition which is associated with the globin chains. You know how many chains there are present?
To alpha to beta.
Okay, two alpha and two beta chains, right? So for example, if you have problem with the alpha or beta chain, that is basically known as thalassemia, right?
Yes.
Okay, so
Yes.
let me make it very simple. So first of all, let's discuss if you have any deficiency or any that disruption of this alpha chain. So it would give you alpha thalassemia, right? And if we
Yes.
have any problems with the beta chain, it's going to give you beta thalassemia, right?
Yes.
So for the alpha thalassemia, basically it is associated with gene deletion, and beta thalassemia is basically associated with your gene mutation.
Mutation.
So normally you have four genes on chromosome number 16 which are encoding for your alpha chains. For example, you have four alleles. For example, if I am knocking off the one gene, it means that this patient would be asymptomatic and won't be having any effect on hemoglobin, right?
Yeah.
Yes.
Okay, if we have deletion of two alleles, then you're going to see mild form. But the problem arises whether it is present on the same gene or the different gene. For example, if you have this condition associated with the same side, like same side, both genes are affected. So it is known as cis deletion on same side. And for example, if you have this one affected and on the other side, these two, so it is transform, right? So cis form is very, like it's dangerous as compared to that of transform. Why? For in case of offspring. For example, if we have a mother and we have a father. For example, if this mother have cis form, it means there are increased chances of this all chromosome to pass into the offspring, right?
Yes.
Okay, like you are automatically transferring both of the defected or bad genes into the offspring. And what if one bad gene come from the father? So there is increased chances of having severe form of thalassemia. That is whenever the three of the alleles are affected. So it can give you severe form. And it's basically found in Asians. Okay, and the trans form is less destructive as compared to the cis form. Like in the trans form, there are increased chances of only having one bad copy in the offspring, right? Okay. And it's basically the trans form is seen in African Americans, right?
Yes.
Okay. So, for example, if the three genes are affected, then what happens?
Moderate.
Okay. If the three are affected,
Hemoglobin H.
yes. So we have alpha and beta chains. For example, if the three are affected, it means the beta chains are going to form tetramers, right?
Yeah.
You'll be seeing beta 2 plus B2, both of the chains coming from B. So this tetramer of beta globin is basically known as hemoglobin H, right? And hemoglobin H can basically damage your red blood cells. Hello.
Okay.
Yes,
So if
yes.
it damages your red blood cells, so it means that it's a kind of severe form, right?
Yeah.
Yes. So you're going to see severe anemia. What if all of these three are deleted? All of these four are deleted. It means you're going to see, okay, for example, in the baby, whenever he is in the, let's suppose, in a fetus, let's suppose, if you are having four of all of the genes being deleted, so you are only left with the gamma chains. So you'll be seeing gamma tetramer, right? As here we were seeing beta tetramer.
Mm-hmm.
Okay, so this BART gamma tetramer is basically known as hemoglobin BART,
Mm-hmm.
and this kind of baby cannot survive.
Yes.
Hello.
Yeah.
Yes, this
Yes.
baby cannot survive. Like,
Yes.
okay, so you are going to, and there is a condition that is known as hydrop fetalis. He would die. Like you are going to see severe edema, all of the severe edema everywhere in this baby, and he would die simply. So hydrops fetalis, gamma chains. Now let's discuss beta thalassemia. Okay, Dr. Ramesh, can you just give us a quick overview of alpha chains and conditions associated, please?
Well, hemoglobin contains four chains, two alpha and two beta. If the alpha chains are affected, then it is called alpha thalassemia. It happens due to gene deletion. Uh, in alpha chains are coded by four genes at chromosome 16. Now, if only one gene is affected, then it will not cause that much of a problem. If two genes are affected, then if it is cyst form, then there is a high chance of getting transmitting the disease to the offspring. But if it is like transform, then and cyst form is more very prevalent in Asian population. Transform has less chance of transferring it to the offspring, and it is more variant in the African American population. Now, if all
Yes.
the genes are affected, then there will be formation of beta tetramers, which is called hemoglobin H, and it is toxic to the RBCs, and there it will form severe anemia. And if all the four of genes are affected, then alpha chains will not be formed at all, and so the baby in fetus will form tetramers of delta chain, which is called hemoglobin bars, and the baby will die in utero.
Okay, perfect. So now let's discuss beta chain problems, right? So beta chain, as we have already discussed, there is some kind of mutation, not deletion. So if there is mutation, it means you will be forming B, but either it would be less or no B formation. Less B formation or no B chain formation, right?
Yes.
So this can be the two conditions. So basically, you have two genes on chromosome number 11 in order for encoding your beta chain. Okay. So for example, beta not represent that you do not have any beta globin chains. So for example, if from one parent you have the normal B and from the other he have B not, it means it's mild form of beta thalassemia. You still have the working gene, right?
Okay.
It's mild or severe? Sorry.
Mild.
Mild.
Okay. So it's mild form. What if you have beta naught plus beta naught, no B chains? Then you are going to see tetramer of alpha chains, right?
Yes.
Yeah.
Okay, because you do not. So it's a severe form, right?
Yes.
Yes.
Okay. So like we were talking about. Okay, what if we have normal B plus, that is less hemoglobin being formed? It's also mild form, right?
Yes.
Or mild thalassemia. Okay, so for example, if someone have major beta thalassemia, that is beta naught into beta naught, it means you'll be seeing some extramedullary hematopoiesis. What's extramedullary hematopoiesis?
Migration of
Extreme.
stem
Okay,
cells out of the
okay.
bone marrow.
Other than stem cell, like in all, for example, in the liver plus spleen
Spleen.
plus
Yeah.
skull, right? These were the location in which usually the like in utero the hematopoiesis took place, but then it was like in later life it is replaced by the bone marrow being producing all of your hematopoietic stem cell. So in this case you are dependent on even on these primitive sources of hematopoiesis. So EPO would be increased and it would trigger your liver, your spleen, your skull in order to generate as much as red blood cells as they can, because they are completely lacks the hemoglobin, right? So
Yes.
okay, so you'll be seeing massive erythroid hyperplasia. You'll be seeing some skull lesion, that is crew cut appearance. Why would be seeing crew cut appearance? Because you are stimulating the erythroid precursor inside your skull, so they would grow in their size, and you are going to see crew cut appearance as a result of that. It indicates the extramedullary hematopoiesis, right? You are going to see hepatomegaly, splenomegaly. Hello.
Okay. Yes.
Okay,
Yes.
and you are also going to see a target cells. Can you just tell me what is target cells?
Central darkening and a ring of pallor.
Okay, how do we see this? How to remember whether we have this central darkening? Okay, let me just give you an good explanation of that. Normally your red blood cell is biconcave, right? And at the mid of red blood cell you have that paler portion, which indicates that you do not have any cytoplasmic,
Erythroid.
or
Yeah.
you do not have any hemoglobin there, right?
Yes.
Yes.
Okay, so if you do not have hemoglobin there, so what if I am decreasing the content inside the red blood cells? If I am decreasing the content, so this membrane is going to become like loosened, right?
Yes.
Okay, you can simply imagine of a ball. If I am removing air from a ball, so it would become loosened and it have increased chances to have these kind of blebs there in the
Yes.
mid, and these blebs would be occupied by these hemoglobin. It can move here into these blebs, so this can give you a target. What is target? Red blood cell, right?
Yes.
Okay, so this was all about thalassemias. We are done with microcytic. Now let's move to macrocytic. Okay, can anyone tell me what's macrocytic anemia? What's the basic definition?
MCV greater than 100.
Okay, perfect. MCV greater than 100. What are some of the causes of macrocytic anemia?
Vitamin
12.
B12 and folate
B12
deficiency.
and
Folate.
folate deficiency. Okay, you guys know that B12 and folate deficiency basically that helps in DNA synthesis.
Yes.
Yes.
Okay, if and you know DNA synthesis is important for your cell division, right?
Yeah.
Yes.
Yes.
Okay, if you have less DNA, it means okay. If you have less vitamin B12 or folate, it means you have less DNA being formed. Simply, you can think of it means you will be seeing less division. If I have less division, it means the cells would be big. Macrocytic.
Yes.
Simply, you can remember in this way. Okay, so that day we discussed that folate is going to come. It's going to be converted into di tetrahydrofolate, right? Tetrahydrofolate is going to bind with yes methyl. It's going to give its methyl to B12, right? Hello,
Okay.
hello.
Yes.
Okay,
Yes.
B12 is going to give methyl to homocysteine. Hello, hello,
Yes.
hello.
Yeah.
Okay, homocysteine, whenever it gets methyl, it's going to be converted into methionine. So, for example, if we have B12 or tetrahydrofolate deficiency, that day we discussed, we are going to see more homocysteine as well. And homocysteine damages your endothelial cells and it increases chances of thrombus formation. Okay, so in this case, that is macrocytic anemia. If you are seeing less divisions, it may due to decreased tetrahydrofolate or B12. So you will also be seeing some thrombus formation, right? Why? Because homocysteine also rise.
Okay.
Okay, so macro. Okay, so no, okay, we can also like for example, if someone is using drugs, you already might have done it. That is methotrexate, which is antagonist of your folate, right? And it disrupts your DNA synthesis, and it can be used as anti-cancer drug, right?
Okay.
Hello?
Yes.
Okay. So methotrexate can also give you macrocytic anemia, right?
Yeah.
Okay. So now let's discuss folate deficiency. So you guys are going to tell me that which kind of individual would be prone to deficiency of folate or folic acid.
Chronic alcoholic.
Okay, alcoholic. Perfect. Okay. Those who aren't eating green vegetables and fruits.
Okay.
Okay. Folic acid or folate is basically reabsorbed in jejunum, right?
Yeah.
What if I cut their jejunum? Okay.
Decrease absorption.
Yes, alcoholic, elderly as well. Folate antagonist. So you will be seeing decreased serum folate. What happens to homocysteine, guys?
Increase.
Okay, homocysteine would increase. Okay. So B12, you know, normally B12 is absorbed like in the inside your in your mouth. Basically, B12 is binded to R factor or R binder. Then what happens, guys? Hello, hello.
Yes.
Just
Yes.
tell me the pathway further, please. Hello, guys, help me. Why are you so quiet? Okay, it's going to bind with the R binder. Then inside your stomach, you have parietal cells that makes your intrinsic factor, right? Then what happens? This R factor is going to be like cleave off by your pancreatic enzymes. Remember that, okay? Then your intrinsic factor is going to bind with it, and it would help this B12 to be reabsorbed in your ileum, right?
Okay.
Yes.
Okay. So, for example, how one can have a B12 deficiency. For example, if someone is having gastritis, let's suppose, or autoimmune destruction of your parietal cells, so it means you do not have what? You do not have
Intrinsic
your
factor.
intrinsic factor. Yes, please. You do not have intrinsic factor. It means B12 cannot be reabsorbed. B12 cannot be reabsorbed. No DNA synthesis. Macrocytic anemia. Simple. Okay. For example, if we have pancreatitis, you cannot like just cleave off this R binder. It means again B12 cannot bind with intrinsic factor and in turn reabsorb. It means again you are going to see macrocytic anemia, right? Okay, so macrocytic
Yes.
anemia, what would happen to neutrophils? Neutrophils normally have five lobes. Till five lobes you can have. If it's greater than five lobes neutrophils, then you can say it's macrocytic anemia, right? So basically, like the active cells inside your body that are neutrophils, your red blood cells, and some cells of your enterocytes, the epithelial cells, you guys know. So they are basically the active cells. It means they turnover more, like their turnover is more, like they are made more and they are destroyed more simply. So it means if I'm affecting DNA by decreasing the level of B12 and folic acid or folate, it means more the active cells are going to be affected, that is neutrophils, red blood cells, and your enterocytes.
Okay.
Okay, so here you are going to see mega or big cells due to their deficiencies because they are the active cells. Okay, so decrease. Okay, so this was all about macrocytic anemia. Okay, what happens to homocysteine level again? Yes.
Doctor, what is the site of absorption of vitamin B12?
It's ileum.
Okay. Okay.
Okay, so this was all about. This was an overview of macrocytic anemia, right? You know the concepts now. So now let's discuss normocytic anemia. What do we mean by normocytic anemia? That you have less red blood cells concentration, but the size is
Normal.
between 80 to 100, right? Okay.
Yes.
So in order to, okay, so you can have breakdown of red blood cells or underproduction of red blood cells in your bone marrow, right?
Yeah.
Okay. So either breakdown of red blood cell or underproduction of red blood cells. So how to check whether it's caused by underproduction or it's caused? Okay, reticulocytes count. Perfect. So normally, how much reticulocytes are present inside our blood?
1 to 2%.
1 to 2%. Okay. So like sometime what happens? Okay, what's the concept of corrected count? Can anyone tell me? Okay, so like normally, for example, if this is your, let's suppose this is complete volume of your blood, and you have 1 to 2% reticulocyte count, it means that 98% are okay. What are reticulocytes? They are immature erythrocytes, right?
Yes.
Yes.
Okay.
Yeah.
So what if like you can have two situations. For example, if you are decreasing the normal, it means again the percentage of these reticulocytes is increased. This is basically false elevation, right?
Yeah.
Okay, if I'm decreasing these normal erythrocytes, so ultimately the percentage of these 1 to 2% is going to be increased. It's going to take more space in this volume. So this is basically a kind of false elevation, right?
Yes.
Mhm.
So in order to have good idea whether the reticulocytes are made or not, we are going to use a term that is known as corrected count. So corrected count, how to use corrected count? Just take the the red blood cells count, okay, and just multiply it with hematocrit divided by 45. So you are going to see corrected count. Okay, this is a formula, you guys must remember that. So if the corrected count is greater than 3%, it would indicate that yes, your bone marrow is good. It's producing well amount of reticulocytes. So it suggests there is some peripheral destruction. If it's less than 3%, it indicates that there is some problem going on with your bone marrow, right? So there is underproduction. No?
Yes.
Okay. So now let's discuss the peripheral red blood cell destruction. Peripheral RBCs destruction. So peripherally, it can be destroyed within the blood vessels or outside the blood vessels, inside blood vessels or outside blood vessels. That is, can be destroyed extravascular or intravascular hemolysis, right? So extravascular hemolysis basically happens in the spleen, if you guys remember. In the
Yes.
spleen, in the liver, in the lymph nodes, right?
Yes.
So, for example, if I'm breaking off the red blood cells, what happens? I'm breaking the hemoglobin, I'm breaking the heme, breaking it into iron. Iron is going to reabsorb. What happens with the porphyrins? Hello?
Increase.
Okay, porphyrin increase. It's going to bind to albumin. It's then carried into your liver. It's conjugated and being released into your bile, right?
Stones,
Okay.
yes, bile stones.
Yes, so it can cause bile stones as well. Yes. So that is gallstones. That is bilirubin derived. Okay. So for example, if I am having exaggerated amount of destruction of your red blood cells, it means there is increased chances of increased like concentration of protoporphyrin, and sometimes your liver cannot conjugate them. So you are going to see jaundice, right? Okay, perfect. There is increased chance of bilirubin gallstones, right? Like in the bile, it is released as bilirubin.
Yes.
Okay. So, for example, now, for example, if one have intravascular hemolysis, so you are breaking it into heme, like hemoglobin is going to revolve inside your blood. So you will be seeing hemoglobinemia. It's going to go into urine, hemoglobinuria, right? And hemosideриnuria. What is hemosideриnuria?
Iron.
Yes, this iron can go into your renal tubules, and whenever these renal tubules slough off, you can see these iron cast in your urine. Basically, it indicates hemosideриnuria. Okay, just give me a second.
Yes.
So, what is the difference between intravascular hemolysis and extravascular hemolysis?
Okay, so intravascular hemolysis and extravascular hemolysis. So, extravascular hemolysis basically happens in your outside the red blood cells. No, sorry, outside your.
Vessels.
It
Vessels.
happens your outside your vessels, right? And it like the content can be metabolized. You know, like the hemoglobin, whenever it is present inside your blood, it's very dangerous. Like it can activate your coagulation cascade. It can cause pain as well,
Okay.
right? So the intravascular hemolysis, you are directly dumping off more hemoglobin in your blood. But in extravascular hemolysis, you have the chances for metabolizing these products, as we discussed.
Okay.
Okay. So
So, so
now,
extravascular happens in spleen.
yes, it occurs in spleen as well. It can occur in the yes,
Liver.
mostly it can occur in the spleen. It can occur in the liver as well.
Okay.
Okay. So the first condition which we will be discussing here is, okay. Just give me 1 second, please. Just give me 1 second, please. Okay. So let's discuss a condition going extravascular hemolysis. We have already done this condition. If you guys remember, hereditary spherocytosis. Hereditary
Okay.
spherocytosis. Okay, just give me 1 minute. Sorry, guys. So, like, there is some emergency. Someone is calling me. Please. Hello. Okay. So we have discussed a condition, hereditary spherocytosis. So what happens in hereditary spherocytosis? For example, you know the cytoskeleton of red blood cells. What's the cytoskeleton of red blood cells? The spectrin, ankyrin, and band 3. For example, if you do not have this cytoskeleton, what happens? You will lose this biconcave structure, and ultimately the red blood cells are going to be in sphere form, and you know this sphere cannot pass your sinusoids, so there is increased chances of destruction, right? We already discussed this. So what's the treatment option? Just cut their
Remove
spleen.
spleen.
Yes, splenectomy. Okay, so you would just lose that central pallor, right? Okay, increase mean corpuscular hemoglobin concentration. Splenomegaly, yes, we are going to see splenomegaly as well, because spleen is working hard in order to kill off your red blood cells. So it would undergo hypertrophy, it would enlarge. Secondly, it's an extravascular hemolysis, right?
Yeah.
Okay, so if I am destroying my red blood cells, so what happens to, can it cause jaundice? Because I am dumping off more of protoporphyrins, right? Okay. What can happen? Can I have bilirubin gallstones? Yes. Okay. So in this case, we are seeing severe anemia, right? The red blood cells are decreasing their concentration. So a person can also enter aplastic crisis by infection with B19 virus. Simple. Let's learn the concept. So, like for example, if a person is having hereditary spherocytosis and you have exaggerated amount of anemia going on, like destruction of your red blood cell, it means again your body is dependent on all of the reservoirs. That is your bone marrow, and any, like it's very dependent on that. So B19 virus love to attack on your bone marrow. For example, during this condition, let's suppose if a person is having hereditary spherocytosis and he is infected with this virus, so he can enter a plastic crisis, that is pancytopenia. Okay, and all of the levels are going to be decreased. Secondly, for example, if I cut his spleen, normally you have like okay, you guys are going to tell me the red blood cell do not have nuclear fragments, right?
Yes.
Mature red blood cells have nuclear fragments or no?
No.
Okay. Why? Because the spleen is going to eat these nuclear fragments from a mature red blood cell. In order to have mature red blood cells, we are going to remove these nuclear fragments. How? Spleen is going to do that work. If I'm just cutting the spleen, it means you'll be having some remnant of your nuclear materials, right? And
Yes.
on smear, it's going to give you certain bodies, which is known as
Well,
Hobble
jolly.
Jolly body. Hobble Jolly. So it means after splenectomy, you'll be seeing Hobble Jolly's bodies. Okay. So now let's move to other pathology. Okay. Okay. Just give me a second. Hereditary spherocytosis, sickle cell disease. What happens in sickle cell disease, guys?
Sickling of hemoglobin molecules in
Okay.
low oxygen condition.
So it's basically autosomal recessive mutation of your B chain. And if this mutation occurs, it means you're having disrupted kind of B chain and the hemoglobin as well, which is known as hemoglobin S, as for sickle cell disease. And hemoglobin S, there is a important association of hemoglobin S, that whenever you are in a stressful events, for example, acidosis, for example, hypoxic condition, these hemoglobin S, for example, if a person is having sickle cell disease, like you can have two forms, sickle cell disease or sickle cell trait. In disease, both of the genes, if you discuss beta, have two subunits. If both of the beta globin chains are affected and they're having hemoglobin S, okay, what's the main pathology of sickle cell disease? If you guys remember, you have a mutation, right?
Yes.
in which
Yeah.
glutamic acid is replaced by valine, right?
Yeah.
Yes.
And as a result of that, you can have beta globin chain, that is sickle cell gene simply. Okay, so beta chain is affected. For example, if one of, for example, if one beta globin chain is healthy and other is hemoglobin S, so it's basically known as trait. And if both of the genes for B are affected, then it's called disease, which is a severe form. So in the
Yes.
stressful situation, that is acidosis, hypoxia, they are going to attack the shape of sickle, right? This is your sickle. The farmers used to cut crops with sickle, right? Okay. So what's the problem with this sickle? Whenever they become sickle, they cannot carry oxygen, right? And you can
Yes.
have ischemic events in your body. For example, if these ischemic events happens in your, let's suppose, bones of your finger, so it's going to give you a condition. What's the name of that? Dactylitis, right?
Vasculitis. Yeah.
Avascular.
Yes.
Is okay, it's dactylitis. That is, you're going to have extreme painful swollen hands due to these vaso-occlusive events, because these sickle cells are going to disrupt the small blood vessel that is supplying your bones, your finger bones simply. So you'll be saying it's an ischemic pain, right? Okay. you know for example, this is your spleen. It can also disrupt the blood supply to your spleen as well, so you are going to see splenectomy. Okay, due to these vaso-occlusive event, it can undergo an infarction or ischemia, and you will be seeing, what will you be seeing?
Hello, jelly buddies.
Okay, Howell Jolly bodies, yes. And if we do not have spleen, we discussed a condition, if you guys remember, encapsulated bacteria, IgM. Spleen give IgM in order to tag them. If you have splenectomy, so there would be increased chances of infection with encapsulated bacteria, right?
Yes.
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 Hello, we already did this in
Yes.
immunology. Okay.
Yes.
It can also undergo vaso-occlusive events in pulmonary microcirculation, right? Okay,
Hmm.
and in renal
Yes.
papillae, if you guys remember, these are your pyramids, your papillae. They already have less
Mm-hmm.
blood supply. So if they have less blood supply, they already have less oxygen. So these red blood cells, whenever enters the papillae, can attain this sickle shape and ultimately block their blood supply. So you can undergo, person can go renal papillary necrosis, sloughing up of your renal papillae.
Yes.
Yes.
Okay, so this was all about sickle cell disease. So sickle cell disease, you are going to see target cells on the blood smear in sickle cell disease. Okay, okay. So, hmm. So this was all about sickle cell disease. One condition which we have already discussed. If you guys remember, all of your nucleated cell, if they want to hide from your complement system, they have, what do they have on their surface?
F. F.
GPI anchor, and upon that you have DAF.
Okay.
Remember, guys, you have did it.
Yeah.
Yes. So if you do not have DAF, so at night time, acidosis is going to activate your complement system. Complement system is going to destroy your red blood cells. Okay,
Yes.
if I am destroying my red blood cells within the vessel, so it would be intravascular hemolysis, right?
Yeah.
And this DAF basically inhibit your C3 convertase. Okay, so absence of GPI anchor or DAF, so this guy would be susceptible to breakdown or hemolysis at night time specifically. Why? Because acidosis is going to trigger your what?
Complement.
Complement system. Perfect. So like mild respiratory acidosis can also cause it. Okay, okay, along with red blood cells, white blood cells are also going to be destroyed. Platelets are also going to be destroyed because they also have this DAF. Remember that. Okay, it is a nucleated cell. Okay, nucleated cell wasn't for that. So what are you going to see? You're going to see destruction. Okay, once the hemoglobin is released inside your blood, so you'll be seeing hemoglobinuria, right? And
Yes.
as I have already told you, hemoglobin loves to activate your coagulation cascade or platelets activation. So you will be seeing thrombosis. everywhere, right?
Yes.
Okay. Okay, so the main cause of death is thrombosis of hepatic and portal and cerebral veins, hepatic veins, but Chiari, right? Okay, cerebral veins as well. So this was the condition which is included in intravascular hemolysis. So
Doctor, can you repeat this whole process again?
okay, sure. Okay,
Thank you.
upon the surface of your red blood cells on your platelets, you have GPI anchoring molecules. On the surface of that, you have DAF. For example, if someone have mutation of GPI, it means you do not have DAF. What is the significance of DAF? It basically inhibits your C3 convertase. It means that it helps the platelets, the red blood cells, to hide itself from your complement system. Like it inactivate complement system and it save itself from complement destruction. If I do not have DAF, if I do not have GPI anchors, it means now your complement system can easily come and attack them and destroy these cells. For example, if I'm having certain genetic mutations of GPI anchors,
Mm.
so I won't be having DAF, so the complement system can easily attack your red blood cell platelets, right? If they attack your red blood cells, it's basically your hemolytic anemia.
Yes.
Okay, so you know the complement system normally is activated in acidic situation, acidic, right? And no, during night time, what happens to your respiratory rate? It decreases. So respiratory rate, whenever it decreases, it's going to activate your complement system. So at night time, so this condition is basically known as paroxysmal nocturnal
Nocturnal.
hemoglobinuria. So at night time, you are seeing activation of complement system. You do not have DAF. You are destroying your red blood cell. So at morning, you will be seeing hemoglobin in your urine. That is dark colored urine. Okay, is that clear now?
Yes.
Okay, guys.
Yes.
So we have two pathologies remaining, and the time is up. I'm going to take another class, so we will be discussing it in tomorrow's session, and we will also be doing white blood cells as well, right? It was quite a big chapter. Okay.
Okay.
So thank you, guys. Have a nice
Thank
day.
you.
Yeah.
Thank you, Doc.
Doctor.
Thank you.
Yes.
Yes. So for tomorrow, can we just like skip the microbiology part and give the entire time for this remaining thing, because we
Sure.
also
Okay.
need
Yes. Yes. Yes.
we also
Okay.
need classes regarding the cancer drugs, because it is very difficult for us.
Anti-cancer drugs. Yes. 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 Okay. So tomorrow we are going to do anti-cancer drugs along
Yes.
with remaining white blood cells and these red blood cell remaining chapter, right?
Okay.
And doctor, there is one more suggestion. I think someone already wrote in the group about it. That can we also start having lectures about biochem, because it's so versatile. We forget it every time we learn it.
Okay. So I have already told you, you guys are going to do it from your exercise, right? And I can do that, but it would affect your revision session.
Yes.
So what do you think?
Okay.
If you want to skip the revision session, so we can have discussion over that. But if you want to do it by your own, so like it isn't problem. I can just do that. But I'm more
So
focused
what
on the
about
revision.
can if you extend a daily
Okay,
class
once we are
15
done with
minutes?
this micro, once we are, yeah, once we are done with this micro, I will try to do biochem with you guys.
Yeah,
I
only
will
ten
try.
fifteen minutes daily, just extended more 10-15 minutes, not
Okay,
affecting the
so
other revision.
okay, I'll try. Like I cannot promise you, but I'll try my best.
Okay, thank you.
Okay.
Okay, thank you.
Thank you, doctor. Thank you.
Thank you, guys. Have a nice day.
Thank you.
Thank you, doctor.
Thank you.
Thank you.